the amount of research that's grown in cancer and a bunch of other areas it's just huge, and that it's really going to be a key component. It should be and will be a key component of how we address Alzheimer's disease, obesity, type 2 diabetes, cancer, all these different things we're seeing all around us in Western nations all have a microbiome driver.
Welcome to the Radical Health Rebel podcast. I'm your host, Lee Brandon. This work started for me several decades ago when I started to see the impact I could make on people, helping them to identify the root cause of their health problems that no doctor could figure out, including serious back, knee, shoulder and neck injuries, acne and eczema issues, severe gut health problems, even helping couples get pregnant after several IVF treatments had failed. And it really moves me to be able to help people in this way. And that is why I do what I do and why we have this show. In this episode, I'm joined by Erin and Jason Hawrelak to discuss their groundbreaking study titled Preventing Chemotherapy-Induced Diarrhea and Microbiota Imbalances with Prebiotics and Probiotics in Breast Cancer Treatment. We explore how strategic use of prebiotics and probiotics can support gut health during chemotherapy, reduce side effects like diarrhea, and maintain microbiota balance during breast cancer treatment. This insightful conversation highlights the power of gut health in cancer care and offers hope for a more holistic approach to managing treatment-related challenges. If you or someone you know is navigating cancer treatment, or if you're passionate about the potential microbiota-based therapies, this episode is essential listening. Jason Hawrelak and Erin O'Meara, welcome to the Radical Health Rebel podcast. Thanks for coming on the show.
Thank you. It's a pleasure being here. Yeah.
Now, it is a first for the Radical Health Rebel podcast because it's the first time I've had two guests to interview at the same time. So I'm quite excited about that. And not only do I have two guests, but two guests on completely different sides of the planet, which is also exciting. One in Australia, one in the US, one in hot weather, one in cold weather. So it's great that we've been able to, manage a time that's convenient for all of us to be able to have this discussion today. To kick things off, could we perhaps, I'll get each of you one at a time to share a little bit about your background, kind of including your educational and professional background, and also what your current position is at the moment. So should we go ladies first? So Erin, if you want to just give us a little bit of background about you.
Absolutely. Yeah, I am a nutritionist in Minneapolis, Minnesota, private practice. And I have a master's in nutrition and functional medicine from University of Western States, where Jason was my GI imbalances professor, and where I got turned on to this way of practicing. Awesome.
That's great. And Jason, quick intro from you.
Yeah, I'm a naturopathic physician and educator and microbiome researcher. I started my delving into the microbiome research about essentially 25 years ago now, when I started my honors with the thesis, or the literature review for my honors thesis around dysbiosis and IBS. And I've been actively in the juggling the clinical practice and research and education really since that time. And that's my absolute passion is the gut microbiome and gut health. Yeah. So it's been, and these days I'm a clinician. I work at the Microbiome Restoration Center, which is my sort of educational institute. And I still work at the University of Western States as well. Because I really enjoy having that interaction with and educating professionals is one of the passions too, that goes hand in hand with the microbiome.
Yeah, absolutely. And for those that perhaps haven't heard, Jason has previously done an episode with myself a while back talking about small intestinal bacterial overgrowth, which has been the second most downloaded episode out of 120 odd. So it was a very popular episode. So I'm sure this is going to be just as popular. And one of the reasons I'm quite interested to speak to both of you, we're going to come on to talk about your research paper in a moment, is because, like you, Jason, I'm very interested in the gut and the gut microbiome. But interestingly, I've had a number of women become clients of mine after already having treatment for breast cancer. which is quite interesting. So I guess, the reason why I've asked you to come on the show is really to share the results of the study that you guys did together on a treatment modality aimed at treating the gut microbiome and how it can potentially minimize or eliminate the side effects of cancer treatments on women receiving treatment for breast cancer. But I guess before we get into the nitty-gritty of the paper, I guess what I would really like to know is what prompted you guys to do the study?
I reckon you're best to answer this one, Erin.
I'll take that. Let's see. Well, full disclosure, I am the patient and author of this paper. So I was regularly testing my microbiome and working on a dysbiotic gut for a few years prior to breast cancer treatment, which makes one wonder a little bit about, was it a contributor? And I had worked with some clients who had been through breast cancer treatment and had seen probiotics, very specific probiotics, work really well for the quote unquote diarrhea drugs. So when I was diagnosed in December of 2021, I knew I had to get together a plan and I didn't know right away that I would need chemotherapy, but I knew that I would have surgery and radiation. So I knew I needed to support my microbiome and not slide backwards in my gut health. I had come so far.
Because you had a history of irritable bowel syndrome too.
I did. Yep. Yes, I did. Yep. Years and years.
So you mentioned, I think the wording you used was diarrhea drugs. Do you want to be more specific what you mean by that for the listeners?
Yeah, I had a client that called it that. She said that, oh my God, I'm going back on the diarrhea drug. And she was a stage 4, metastatic breast cancer, 10 to 15 years. She lived with that. But she didn't want to do the testing. So we didn't test back there. And it was kind of early on in my getting into gut health and specifically the microbiome. So we didn't test. And I think too, that kind of also shows the capacity of women going through this. It's incredibly intense. And so people's capacity for taking another test or seeing another practitioner can be kind of low, but she said, I just need help. And I know you talk about probiotics and particular probiotics and what can we do? And so then she had really good results from that and told her surgical oncologist at the University of Minnesota. And he adopted, those 2 probiotics. And so that kind of started it all right there.
So just to clarify, when you're talking about diarrhea drugs, you're talking about chemotherapy, right?
Yeah.
So obviously you were the person in the study, as you said. But what was the motivation to actually make that a study?
Yeah. So I had taken a workshop years before on case reports, so that's always been on my radar. And when something kind of, interesting or even, dare I say, miraculous happens, I think about writing a case report. So in my own case, you would do a follow-up. I had 4 rounds of chemotherapy, and after each round, later you would go in and see a nurse, and she would go ticking boxes down a huge list of symptoms, and she would stare at her computer and say, list all these things, and you'd say yes, no, and we'd get to diarrhea, and I'd say no, and she'd every single one of them would turn away from the computer and look at me and say, no, everyone has diarrhea on these drugs. And then I would say, well, do you want to know what I'm doing? And and conventional people in conventional medicine sometimes are interested, but usually not super interested in what I'm doing. But anyway, so that then was working closely with Patricia Kaufman, our co-author on the paper. On other things, we get together and discussed cases and things like that regularly. She's in California. And we mentor regularly under Jason. And so it just kind of came together that, gosh, we should really write this up, because especially when I was able to avoid diarrhea or any backsliding on IBS, you know?
Yeah. Yeah. So again, we'll probably come on to it, but obviously, as you were saying, you had a history of IBS, and, you know, what I got from the paper is oftentimes people receive the treatment, i.e. chemotherapy, and then it's bad enough they're dealing with cancer, they're dealing with chemotherapy, and now they've also got diarrhea to deal with as well, which, you know, has all kinds of issues in its own right. So I'm guessing from what you've said is the major motivation was, we need to get this information out there. More people need to know this information. Would that be right?
Absolutely. Yeah. I think we could help many, many people, and outside of breast cancer as well.
Yeah, absolutely. Absolutely. Okay, so just to kind of overview again for the audience. So the study was you. So you were 57 years old at the time. You don't look 57 now, actually. So well done. You must be doing something right.
It's my microbiome.
Yeah. So you, as you said, you're receiving chemotherapy for breast cancer. Can you, or either of you, explain to the audience what are the common side effects that you discuss in the paper from the chemotherapy itself?
Okay, Erin, I think you're probably best placed to.
You think so? Okay.
Well, you experienced it, and you would have delved into the potential.
Yeah. Well, all kinds of functional GI, symptoms. But the main one is diarrhea, and that's what's expected, and bloating, and certainly when in the day or so following an infusion, I would have mild to moderate GI upset. You know, one of the drugs I took in the first infusion was an antibiotic, a tumor antibiotic. You know what I mean? It's the adriamycin. They call it the red devil, and so that's really expected to give you diarrhea. Yeah. So diarrhea, gas, bloating, but the diarrhea can really lead to some really significant problems. And I've met women that have dealt with this, or they end up in the hospital because they're dehydrated, their electrolytes are out. It's just makes it not possible to tolerate the chemotherapy, and sometimes the chemotherapy has to be stopped.
Yeah, I think those are great points, Erin, because I think sometimes you go, diarrhea, like it's like pooing once or twice more frequently per day. It's like it can be far more intense than that.
Yeah,
cause significant disability and treatment and cessation of treatment, essentially, which is not what we're wanting in that situation at all. And their quality of life will go down when they're already dealing with a bunch of other things. And I think there's also that some people do get longer lasting gut symptoms that persist afterwards. So you get an acute diarrhea episode that might be manageable at the time when you're juggling a bunch of other things, but certainly not ideal. But then you might get stuck with a dysfunctional gut for months afterwards too, and that's certainly something we wanted to prevent as well. And that's where I think this approach of trying to protect the microbiome from harm and help encourage the beneficial microbes to regrow after these sort of very dysbiotic inducing medications is a key strategy there.
Yeah. So from what you're saying, chemo causes these gastrointestinal issues. How does the chemo actually disrupt the microbiome? Do we know what the mechanism is? And is that understood?
Well, I mean, I think we know each agent will be a little bit different in this regard, but in general, what we see is a overgrowth of more pathogenic bacteria, particularly proteobacteria. and a reduction of beneficial bacteria. And that would include butyrate-producing species, bifidobacteria, and overall diversity. Yeah, so you'd see it has essentially having an antibiotic-like effect in terms of this microbiome, and almost selectively for killing good bacteria and increasing levels of bad bacteria, which is not uncommon with antibiotic use as well, for that matter. So that's kind of the impact on the microbiome is that. And then we will see increased inflammation that occur because some of the proteobacteria we know tend to have very pro-inflammatory endotoxin in their cell wall, which will increase gut inflammation. And at the same time, we're taking away sort of the protective anti-inflammatory species like bifidobacteria or those that make butyrate, which essentially will impact the appealing of the gut cells to heal. Because that's the other thing too, is that chemotherapy kills fast-growing cells, and some of the fastest-growing cells in the body are obviously cancer cells, but beyond that, it's gut cells and immune cells, and those are the areas that tend to be more severely impacted by chemotherapy. And at the same time, they're killing the bacteria whose job it is to heal the damaged gut. Because I think we sometimes forget this, how vital the microbiome, and particularly butyrate-producing bacteria, are for healthy colonocytes. We know that 70% of the energy needs of colonocytes are met from bacterial byproducts, short-chain fatty acids and butyrate made. Essentially, it's the bacteria that are feeding and nurturing those colon cells. And if we're smashing down those bacteria, at the same time killing those cells, that's where we get these sort of side effects. So we're really trying to create an intervention that would limit both those things of going, okay, well, can we speed up the healing of the gut itself, and can we protect the protective species in the microbiome and help regenerate them more quickly after the chemotherapy sort of insult.
Yeah, I mean, I'm sure a lot of people believe that all health, or you could say all disease, starts in the gut, right? So the last thing you want.
I'm in that camp for sure.
Yeah, absolutely. But when you think, again, you've got cancer, you've got the chemotherapy, the last thing you want is your gut not performing at its best, because as you say, that's what's going to help you heal at the end of the day. So if you can negate any of the negative aspects of the treatment, that's only got to be a positive thing, right?
Absolutely.
Yeah, and it is interesting looking at sort of the broader microbiome and cancer field, and I think this area is truly starting to boom now, and I think this will bring the microbiome on the radar of current clinicians who don't, where it's not. And I think God, you have to get your head in the sand for it not to be the case. But truly, there's still people out there who don't think microbiome. Don't think it matters. Don't think it's too early to do anything about it yet. So just we'll ignore it for 20 years until enough research builds up. But I think some of the research around how the microbiota is seen as like a driver of cancer development, how the composition actually can modulate treatment efficacy, and this is very clear in maybe not so much research yet in something like breast cancer, but in melanoma, like skin cancer, it's immensely clear from the research that the composition of your microbiome at baseline when you start treatment can dictate whether you respond or not to immunotherapy approaches. Like you can get like zero efficacy if you've got like a Bacteroides dominated ecosystem versus 67% efficacy if you've got a Fecalibacterium dominated ecosystem. It's like dramatic difference, in outcomes. And I think that that research is going to spread beyond just like the skin cancer area to looking at, it's already there in the colorectal cancer area too. But to move towards breast cancer too, we're like, okay, this microbiota composition impact how you respond to these agents that we're using. And our focus here was really on twofold: was to protect the microbiome from harm and protect you against getting the gut side effects that would typically be the case, and restore the ecosystem afterwards. But there's even focus on how we can reduce chances of cancer recurrence by altering the microbiome too, because there's just certain bacterial species that seem to play key roles in cancer progression that we're really delving into in greater detail in the last sort of 10 years.
Yeah, I mean that sounds like music to my ears. That that's being looked at as an approach, for treating cancer. Again, if you think all disease starts in the gut, why would you not start there with the treatment protocol? And also, if you compare the potential side effects of what might be called conventional treatment versus that kind of treatment, which, I mean, the side effects are normally positive anyway, if there are any, right? So that makes a lot of sense to me. So let's fingers crossed that research is allowed to happen, because I know there's some vested interest that might not want that to happen. So yeah, fingers crossed that does continue. So we've mentioned, so people go on chemotherapy, it has a antibiotic-like effect, it causes issues like diarrhea. What are some of the standard treatments for things like diarrhea when someone with breast cancer has diarrhea, because of the chemotherapy? What treatments are normally given, and what are the knock-on effects of those treatments?
When 35-year-old Amanda first scheduled to see me, she'd been suffering for 19 years from severe IBS, diarrhea and fecal incontinence, along with abdominal pain and bloating. Her condition had not only made life uncomfortable for Amanda, but very inconvenient, as she had to walk 2 hours to work every day along a route that had public toilets, and she'd never been on holiday as an adult because of her condition. The only advice that several doctors and specialists had given Amanda was to take Imodium, and when she first saw me, she was taking 5 Imodium a day and wasn't getting any better. To help Amanda, I ran tests to find out what foods were right for her metabolic type, to see which foods she was sensitive to, and to assess her gut microbiome. Tests showed that Amanda had several food sensitivities and a parasite infection. Over the coming weeks, I coached Amanda to eat right for her type and to replace the foods she was sensitive to, and a protocol to deal with her parasite infection. And after 3 months, Amanda was IBS-free, and she also reported her skin was much improved and she had lost weight. And she booked a holiday for her and her husband to New York, as they'd never been on a proper honeymoon because of her IBS. And if you're suffering like Amanda was, and you want to get to the root cause of your problem, you can arrange a consultation with me at www.bodycheck.co.uk. And if we're a good fit, I could help you achieve the same kind of results as Amanda. Now, back to the podcast.
Yeah, the only thing I was offered was antidiarrheal medicine, and that has the side effects of slowing down motility, and with that could come a rise in proteobacteria and more dysbiosis. Yeah, so that was the only thing that was offered, and I knew I didn't want to take that because it felt like a Band-Aid that wasn't getting at,
Yeah.
Really, it wasn't supporting me. It was, yeah.
Yeah.
Yeah, I guess not fixing the underlying dysbiotic changes or gut damage that's caused the diarrhea. It's just stopping, the diarrhea.
Yeah.
It be a type way.
Yeah. And the other thing, I guess, again, if someone's got cancer, the last thing you want to do is stop toxins being released through the colon, right? Because obviously if you're holding on to more stuff and now you're becoming constipated, your body's going to be holding on to toxins, which, I would imagine, I'm no oncologist, but I would imagine that would not be a favorable thing for someone that has cancer or have just been treated for cancer.
For sure.
Yeah, that's right. I think if it actually did have the end result of you not pooing at all, and really, really slowing down the gut, which is obviously from a symptomatic, okay, you don't have diarrhea now, that's an improvement. But if it stops things from moving at all, you will be reabsorbing, bacterial toxins that are released and potentially, argue environmental toxins too that your body's trying to get rid of through that way. And even your hormones might be altered by that process too, because we know that the longer fecal matter sits in the colon, the more it sort of interacts with bacteria, and the more sort of you'd argue toxins are produced and or released in that process, just because of greater chance of bacterial enzymes like beta glucuronidase to play a role in that, for example, or greater chance for endotoxins to be absorbed, which again, as you noted, are neither of which is particularly going to be helpful overall for that person's health.
Yeah. One thing I think would be quite useful for the audience is if you could perhaps give an overview of how you actually did the study. If you could just break it down. Now, obviously, we now know, I didn't know, but I now know the participant was you, Erin. But if you could just break down almost like a timeline of kind of what you did and what was found.
Okay. Well, let's see. So we realized partway into my chemotherapy that maybe we'd want to do a case report. So it's really kind of a retrospective putting together of the past events, right? Because you've noticed something cool has happened, and you want to go back and say, what did we do? And luckily I keep good notes about, and test my microbiome regularly. So we had that data, right? And so then I guess we just, we started to dive into the literature we knew as clinicians and researchers that when we chose the different remedies that I took, that they had the evidence behind them to support what we were trying to do. But we went and compiled all that together and wrote it up. And
so if I could just take you back. So I'm just thinking back to when I read the paper. The first thing was you did a series of tests at the beginning.
There were 3 tests over time. Yeah. So.
Yeah. And can you explain what you did in between each test and kind of what the results were of each test?
Yeah. Okay. Yeah. So I had a baseline test that I took in April of 2021, diagnosed again in December. So a little bit before heading into treatment surgeries that I started with. And what were the results? You want to know? Like butyrate producers were at like 35%, so a good number. Proteobacteria.
So for the audience, let's just say that's
so
good
my
bacteria,
beneficial
right?
bacteria, the short chain fatty acid producers, the butyrate producers, were at a good level, and my pathogenic bacteria was well within a healthy range. Bifidobacteria was below kind of like where we like to see it at that point, and I can tell you kind of how that went over time. Diversity was pretty good. Okay, I've had a lot of antibiotics in my lifetime, so my diversity is something that I'm always trying to work on, and I'm only able to work with what I've got, right? But we really wanted to support.
Yeah, that's right.
So then kind of timeline diagnosed, lumpectomy surgery, another surgery to get good margins, a surgery to place the port, the chemotherapy port. And then we retested before I started chemotherapy, but after those surgeries.
So what was the time gap between those?
Those 2 tests, almost a year. And this is a limitation of the study, right? Like it would be really great if we had started it just before surgery and maybe done one between each surgery and not just surgery, but the stress of a cancer diagnosis is huge. And stress, we know, is a huge factor in gut health, right?
Yeah.
Yeah, and I think the reality of trying to implant more, when you're dealing with, you just got that diagnosis and you're like fast track into
exactly right.
at this juncture of time.
Yeah.
In hindsight, sure, but at the real time, it's just like we're lucky that we just had one that was not too far apart and you hadn't really changed your diet or lifestyle. So we would expect the microbiome to stay pretty similar up until the point where you got the diagnostic label placed, and then that's where things are going to change. I agree. Like, geez, that's one of the most stressful things you can ever be.
Yeah.
Here is given the C word diagnosis that, and that inevitably will have impacts, let alone the surgeries and antibiotic exposure during surgery too.
Yep, for sure.
Yeah.
So in March of 2022, just before chemo, I tested again. And those butyrate producing bacteria had cut about in half, less than half. And proteobacteria had about doubled. And bifidobacteria, interestingly, went way up. But I believe that that's because of the bifidogenic effects effects
The
from
prebiotics you're
from
saying.
the prebiotics on the.
Okay, so can you so when did you start taking anything like prebiotics and probiotics? At what point?
Yeah, so even in
did they begin?
April of 2021 and before diagnosis, I was probably taking, a maintenance kind of a dose of some pre and probiotics, probably PHGG and maybe LGG or something like that for probiotic. But then in January, we were like, oh gosh, let's kick up the lactulose. And because of my IBS in the past, lactulose was a really hard one to ramp up for me. But I pushed through it, and it's had really, really good effects on shifting my entire ecosystem. But then also in March, quite a bit. And so that was interesting. Then I tested again in August of 2022, had the 4 rounds of chemotherapy and radiation therapy by the time I did that last test. And with the pre and probiotics and lifestyle, Mediterranean diet and everything, the butyrate producers really ended about the same place that they had started. And proteobacteria had,
which is great.
And proteobacteria was lower than my baseline. And bifidobacteria was up, not as high up as when I had first started the lactulose, but higher than baseline. And diversity did not quite make it to baseline, but did bounce up again from March to August. And I did the testing about, I should have looked at this. I could look at the timeline. I want to say it was about 4 to 6 weeks after I finished radiation treatment. I tested again.
Okay.
Yeah. So I guess had you not have been using the prebiotics, you would probably have expected much worse results from the final stool test, right? I don't know. I mean, I've never seen a stool test from someone that's just had chemotherapy. Have you guys seen that before?
We certainly we cover some of the literature in the paper itself, but you tend to have decreases in bifidobacteria diversity, butyrate producing microbes, and at the same time blooms of proteobacteria. So some of those things were expected, but I do think that it was definitely blunted because the increase in proteobacteria that might sound like a lot, was actually relatively small, speaking compared to what you would often see. And that's where I think lactulose has got this amazing capacity to reduce overgrowth of proteobacteria and prevent the overgrowth, particularly through its capacity of acidifying the colon. And there's no agent we're aware of that can acidify the colon to the same degree as lactulose. And I think that is really how it works so well at preventing and reducing overgrowth of proteobacteria. And for those of you who are less familiar with the proteobacteria phylum, and it's a broad phylum, which means that there's lots of different microbes in there. But you'd be familiar with the ones that are problematic are in the Enterobacteriaceae grouping, and that's E. coli, Escherichia, Klebsiella, Haemophilus, Citrobacter, Clivera, Enterobacter are common ones that kind of bloom in that situation, and their endotoxin is just that they're growing in this cell wall is immensely pro-inflammatory. Many of them also produce colibactin, an actual genotoxic agent that can cause gut damage too. So I think they are definitely core contributors to that kind of the symptoms we see after chemotherapy because of their sort of pro-inflammatory gut damaging potential.
Yeah, so you're saying lactulose is really useful in that situation. Lactulose is prescription only, isn't it, in the US?
And in going to conventional medicine practitioners and saying, I want lactulose to avoid diarrhea might be a little counterintuitive, right? Because they think of it as this age-old remedy for constipation. But I have a lovely primary care doc who's integrative medicine practitioner, and she's prescribed it for me. So,
yeah,
it's interesting because I think it's often prescribed for the treatment of hepatic encephalopathy, like end-stage liver disease, and conventional medicine too. And they're like, why would you want that substance? But they never really quite clicked that the reason it worked is it reduces levels of toxic bacteria in the colon and prevents the release of brain inflammatory compounds. That's how it works for an hepatic encephalopathy. So it's like, it's always worked for these gut things, but it's just never really clued that that's why people are taking it for. And the dose is very different. We're trying to treat constipation. It's like 30, 40 milliliters in one hit, whereas the prebiotic dose is like, the minimum prebiotic dose is 1 teaspoon, so 5 milliliters, so far less than that. And people are often surprised to know that lactulose was once added to formula, infant formula. It was the first sort of prebiotic added to formula back in the 1960s, I think it was, and it prevented or it encouraged a more normal sort of microbiome in those babies compared to normal formula, because it's kind of got a drug kind of feel about it in the US because of the way it's classified, whereas I think every other country in the world is not a prescription drug, and you can buy it at any sort of drugstore, chemist, pharmacy, but it is often in the laxative section. So it does require a bit of an explainer of why, people before my shop started selling ASA, I would have to tell my patients to go to the chemist, pharmacy to buy it, and you have to go to the laxative section. But ignore all separate laxatives. This is the dose you take, etc., and take a lot of explanation to get their head around why, because they're kind of, I suppose, sometimes using it off-label because the main reason it's promoted in most countries is not as a prebiotic but as a laxative agent, and it's very effective as such as an osmotic laxative in larger doses. But in the smaller doses, you just have that really amazing capacity of encouraging bifidobacteria specifically, but also important gut microbes like Faecalibacterium prosnitzii. For most of us, our key B rate producing microbe will go up with lactose ingestion. And you have those reductions in those more problematic species like the Proteobacteria I mentioned before, but also Bacteroides as well. And Bacteroides is one of those genus we consider to be a pathobiont, that larger amounts are problematic, smaller amounts are quite okay. But we know that there's Bacteroides fragilis, that one specific species in that genus that does seem to have, pro-cancer type impacts too, and through its production of Bacteroides fragilis toxin, which is clearly tied in with, colorectal cancer and other cancers too. It's really, and even Alzheimer's disease too. It's a really problematic toxin. So lactose does have that capacity of decreasing Bacteroides populations too, which is an added bonus.
Yeah, interesting. So we've spoken a bit about prebiotics. I don't think we've spoken too much about probiotics yet, have we? Do you want to explain what you used in terms of probiotics?
Sure. So we very carefully chose specific probiotic strains to support my gut through chemotherapy. So Lactobacillus rhamnosus LGG, or GG, I guess. And would you like to know why we chose that? I guess that's that one's supposed to help increase epithelial cell synthesis and to help with gut healing, increase diversity, and to keep those pathogenic bugs down. And then we also used Saccharomyces boulardii and a particular strain that Jason can probably rattle off, but I don't have on the tip of my tongue. Anyway, that one.
CNCMI 745.
And that one is known to increase antibiotic-associated diarrhea, keep pathogenic bacteria down again, to keep inflammation down, and to also increase the activity of the brush border enzymes.
That one's also pretty cool because its capacity to, as it traverses through the gut, it releases these compounds called polyamines, which speed up gut healing and gut regeneration. So that's an added bonus. But it also breaks down bacterial toxins. It's even endotoxin too. It secretes its own alkaline phosphatase, which breaks down LPS endotoxin too. It's a pretty phenomenal microbe, actually. And very well indicated for well researched antibiotic associated diarrhea, where we have meta-analysis level data showing it protects against the development of symptoms and it protects the microbiome and helps regenerate more quickly after that kind of insult. There's less research in chemo diarrhea with probiotics at all, actually, to date. So we're kind of had to extrapolate some of the stuff from the probiotics have the best evidence in antibiotic associated diarrhea. We assume we're going to work similarly with chemo because the overall impact on the microbiome is pretty similar. And, arguably you get more gut damage, obviously, with chemo than you do with typical antibiotics.
Yeah. So is it understood what mechanism is used, if you like, for want of a better phrase, by using probiotics, how that helps to prevent diarrhea? Is the mechanism understood? Hey there, Rebels. I have got something very special to share with you today. Did you know that every month I release an exclusive No Punches Pulled episode? These are conversations you won't hear anywhere else with incredible, sometimes controversial guests who expose hidden truths, challenge corruption, and bring you to actionable steps to take charge of your health in a world where censorship and restrictions are on the rise. These subscriber-only episodes go deep, and for the price of a single takeaway coffee each month, you can become a paid subscriber to access this extra content, the kind of content certain authorities would rather you didn't hear. By subscribing, you're not just supporting the Radical Health Rebel podcast, you're helping bring even bolder, more controversial, and inspiring guests onto the show. You'll also be making an investment in real health, real truth, and real solutions, so much more meaningful than what you get with TV licenses, cable subscriptions, or film streaming giants. If you're ready to support this movement for health and truth, head to the show notes and click support the show. It takes just a moment, so why not do it right now? Then come back and enjoy the rest of this episode. Thank you for listening, subscribing, and for rebelling with us against the mainstream. Let's create a healthier, happier, and fairer world together. Go to the show notes, click support the show, and let's keep the Radical Health Rebel movement growing strong.
I mean, I suppose there's a few ways in which it could occur. I mean, I think, reductions of over-risk pathogens would be one of those. I think decreasing gut inflammation would be one of those as well. And potentially, as I mentioned before, sort of breaking down bacterial toxins that might be involved. Like you can look at Clostridioides difficile, diarrhea, which is what we typically see after antibiotics. Yeah. Really more broad-acting antibiotics like clindamycin, for example. And it's the toxins from the C. diff that are pretty problematic. And if you take the right Saccharomyces, it breaks down those toxins and stops them from causing gut damage, inflammation. Yeah. So there's a few ways there, and potentially through their secretion of short-chain fatty acids and encouraging an environment more conducive to the growth of beneficial microbes who then produce their short-chain fatty acids, which again help regulate motility too.
Yeah, awesome.
Lee,
awesome.
Excuse me, just a second.
So,
there were four other
sure.
probiotic strains we also used, and we used those just right around the infusion time, and chose those for for their chemotherapy-induced diarrhea, lowering capacity, and then also bloating and diversity, and again keeping pathogenic bacteria low.
Yeah. So if I was to summarize the paper, so you can check my homework to make sure I've understood everything. So, and again, this is to summarize for the audience as well, just to, again, make sure I've got it right, but make sure the audience understand. So basically, when women have breast cancer, they go for chemotherapy, it has an antibiotic effect on the gut microbiome. That leads to a lowering of the good bacteria that allows overgrowth of the more pathogenic bacteria. That creates the diarrhea. And by using prebiotics like PHGG and lactulose and supplementing with specific strains of probiotics, that almost negates the effects of the chemotherapy and helps to, I mean, in this case, in this study, prevent diarrhea.
Yes.
Would that be correct? And something that you mentioned, you mentioned it in the paper, and you've mentioned one of these already today. But what limitations were there in the study, and what further research would you like to see performed in this field, or indeed like to perform yourself?
Do you want to take that, Jason? Or okay, let me just. I'm just take me a second to refresh my.
Well, you can both take a turn each.
Okay. I mean, I think, again, in hindsight, like if we had kind of come up with it beforehand, okay, this is the case study, and you didn't have all the stress of everything else going on, you might go, okay, well, let's do more frequent stool sampling at different time points to gauge impacts, in more sort of smaller time windows. That's something that I think would be interesting to do. Yeah. And I mean, I think, you could argue about, using a test that using shotgun metabolic sequencing to go deeper into like, species level changes, where we chose a inexpensive, easy to come by 16S rRNA testing, because the cost points is low. Yeah. And we see accurate level at the genus level, accurate data at genus level, not so much at the species level, but genus level is very accurate. And we get, good picture of diversity from that tool too.
Yeah. I guess, money being no object, I would guess that it would be, I mean, you don't wish that anyone gets breast cancer, but for the study, I guess a larger number would be useful, I guess. And even having a placebo control group as well would be quite good to compare the two. But would that make sense?
Yeah, I totally hear that. And I think there's ethics around using placebos in certain conditions, and I would argue that this would be one of them. I mean, other people would argue differently, but where you have something that can, reduce harm, reduce side effects, that is placebo ethical in that situation.
Yeah.
Obviously the best data that we accept as evidence comes from, placebo controlled studies, but I do think there are times where we don't think that placebos are ethical. And so, I think the next step would be doing like a larger case series of the same sort of protocol. And then you can kind of go from there in terms of, how much evidence is enough evidence, what sort of study designs are acceptable for making clinical decisions on. Like those are broader questions. But if you had 30, 40, 50 women doing the same protocol, all getting great results, then I think, okay, many clinicians will be satisfied with that. That particularly for me, when there's no risk of harm from interventions, or the risk of harm is minuscule, that the quality of evidence required showing efficacy to me can be less. So you've got a novel agent that's never been ingested by humans before. I have no idea what the side effect profiles are like. I want really good evidence that it's both safe and efficacious. Whereas when we're like, eat a Mediterranean diet, take these prebiotics that we know are immensely safe, that I think that for me, like a lower standard of evidence is required for efficacy for me to implement on my patients, because there's just not much risk. Whereas I think when the risk level goes up, you want much higher levels of evidence of efficacy, essentially.
Yeah, that makes sense. I hadn't thought of the ethical point of view, but I completely agree with that. Makes sense.
Yeah, there was another limitation, I guess, is that the confounding factors, right? There was a lot going on here. I took a lot of different prebiotics. I took a lot of different probiotics. I was eating a good Mediterranean diet. I was myself to exercise through most of it. When you're really hit hard with chemo, that's pretty difficult, but even walking can help with how you feel. and probably motility and things like that. And I was getting a whole bunch of integrative therapies too. I was getting shiatsu and acupuncture, and so there were all these different lifestyle things too that in nutrition research is can be difficult because there's just so many different confounding factors.
Yeah, and then how do you control for that? Do you go, hey, well, you go eat a standard Western diet while going on this, so we can take that Mediterranean out of the equation? No, of course not, because that we know will cause harm and worsen outcomes from chemo, and worsen outcomes from cancer perspective and just overall health perspectives. So some of those things are like, we want all patients to do anyway, eat a probably plant-based Mediterranean diet, eating the rainbow of colors, variety of foods, because that's the best, arguably, diet for numerous factors, metabolic health and even cancer risk too, I would say, and cognitive health, but microbiome health too. Yeah, so I think you're right. That was one of the things of this paper took so long to actually get through peer review. They kept sending to more and more peer reviewers because they just couldn't understand, like you didn't do one thing, you did multiple things. Like, what the hell? You did diet and probiotics, not just one agent. It was just like mind blowing to them that people could do this. Because I think they're really stuck in that model of the only thing you change is one thing, nothing else changes. Just give this one thing, and you see. Whereas for us, it was not about that. I was trying to get the best outcome for this person, and that requires really, as a clinician, you do multiple things. We're doing the Mediterranean diet, we're doing exercise, you're doing stuff to help manage stress, your movement, and it's like a bunch of different things to get the best outcome for this person. So you can't say that, okay, the outcome we had was due to specifically pre and probiotics. Sure, it's due to the entirety of things. But I think we know that from the microbiome perspective, we would argue that the key interventions there were the pre and probiotics, and it was just really important to get that information out there so that other patients don't have to suffer the diarrhea drug and get the gut in months of IBS-like symptoms afterwards if they can be prevented. And that was a good first step, because that's the lovely thing about case reports is they get that information out there. They stimulate thinking, stimulate researchers, stimulate clinicians to go, okay, I can implement these things. They're stuff we chose for stuff that were commercially available. It's like stuff that everyone can access. Food testing is commercially available. That's, I think, the strength of our study too, is we didn't use this like full on, novel probiotics or novel prebiotics or novel testing that no one can access. It's like, every patient can access all these things we used here and achieve, at least microbiome support and protective qualities of those agents.
Yeah, I guess the other thing that I'm thinking as well is that what might be really useful as well is to have some long-term follow-up as well, because as we know, sadly, there is a lot of reoccurrence of cancer, and if, let's say, I don't know what the figures are, but let's say on average, someone might go 6 years cancer-free, and after 6 years on average, the same cancer or another cancer comes back. But if continuing these protocols 5, 10, 15, 20 years and there's no reoccurrence, it's like, well, okay, now we're onto something, right? So I think maybe that kind of long-term follow-up would be really useful.
Actually,
as well.
I'm talking to a surgical oncologist who's interested in doing both intervention and long-term studies.
Julie, a 47-year-old who works in computer sales, came to see me complaining of lifelong irritable bowel syndrome, which included severe abdominal pain and bloating, loose and very frequent stools, along with hot flushes, menstrual brain fog, and low energy, which affected her work performance. After taking a comprehensive history, plus running some labs, I discovered that Julie had a parasite infection, which may have been causing the loose stools, a methane-producing bacterial overgrowth that was almost certainly causing the abdominal bloating and pain, a leaky gut, low levels of digestive enzymes, as well as eating too many high oxalate foods on her vegetarian diet. So Julie reduced the high oxalate foods from her diet, plus she took a broad-spectrum antimicrobial supplement to help with the parasites and the bacteria in her gut, probiotics to increase her good bacteria and help repair her gut lining. She also took prebiotics to help feed the commensal bacteria, digestive enzymes to improve her digestion, and herbs to help clear the toxic lipopolysaccharides from her system produced by the overgrowth of gram-negative bacteria. At the end of the program, Julie reported that her health had never been better. In her own words, the improvement is staggering. The abdominal pain and bloating was gone. Her stools were back to normal. Her energy was up. She no longer had brain fog or hot flashes, and her immune system had improved as she no longer suffered from frequent bugs and colds. If you're suffering like Julie was and you want to get to the root cause of your problem, you can arrange a consultation with me at bodycheck.co.uk. That's BODYCHEK. And if we're a good fit, I could help you achieve the same kind of results as Julie. Now, back to the podcast.
Yeah.
It's fantastic. Yeah. And I love it when there's a conventional physician who's curious and sees the benefits and actually is happy to chat about it. Because my observation with many clinicians in the conventional world is a lack of curiosity. That they're like,
great.
Oh, you didn't get diarrhea? Okay. And they don't care what you did. They have no interest in like finding out what you're doing differently than the 95% of people who are getting diarrhea. So when you have someone who actually is like, whoa, my God, that's like different. What are you doing? And the dudes can go look at the research on it, because it's not these things that have studies on them. They're not like made up things. The research is there. It's just people are generally ignorant of them because they haven't spent the time to look at it, as yet. So it's I always find it so heartening to find those curious clinicians are like who want to go learn more.
And this particular doc is also interested in not just crossing our fingers and hoping that it doesn't recur, right? She's interested in how could this affect future outcomes.
Yeah, that's good to hear. I'm sure both you guys have found the same experience as me. After many years, and you work with a client or a patient, and they've been seeing a doctor about a certain condition. The doctor hasn't really helped them. They work with you for a few months. They've solved their problem, and they go back to the doctor, and the doctor said, "Oh, what do you mean? What do you mean you've got rid of that? It's impossible." And they say, "Well, I changed my diet and I did it and that." And the doctor normally says, "No, that wouldn't have done it." Right?
Yeah.
There are certainly occasions like that.
Or at best, they might say, "Well, just keep doing what you were doing."
Yeah.
Rather than asking more questions. And I guess, to be fair, most doctors haven't got time to even ask. So what was you actually doing?
No, fair point. I think they spend an average of 7 minutes with people. And it's just like, how can you cover lifestyle? Can you cover diet? What can you cover in 7 minutes besides, pharmacological interventions? That's, and which is a major problem with the current medical model, for sure.
Yeah.
Absolutely. And I think I was extremely lucky. Maybe this is a hub of, progressive practitioners, and the system that I was working in, which was the public health system, many, many really curious, fabulous doctors, open-minded enough to, maybe not curious enough to go the next, what to do or whatever, but at least open-minded enough to, oversee and allow me to do these things along the way. Although I think they all sort of saw me coming and were like, "Oh no, here she comes again. What study is she bringing, and what kind of remedy does she want to go on?" But
that's the well-read patient.
but they were fabulous, really.
Yeah.
No, that's good. That's good. And as I said earlier, you're looking fantastic, Erin. So, whatever you've been doing is obviously doing something.
I bounced back really nicely, and I attribute that to what I did to support that as well.
Yeah. So, the reason I asked you guys on is because I think this is really important information to share, and I'm going to invite anyone who ever's got to the end of this interview. I'm going to put a link to the study in the show notes. And, I just want people to share not only this episode, but also potentially share the paper as well with people that are perhaps going through that experience, because it might be really useful information. And, like we've kind of alluded to, not only might it create a better experience if you're going through that modality of treatment, but it may well, again, we don't know yet, because as we say, there's no long-term
information on this, but it might well create a much better long-term outcome as well. So I think it's really important if people could share this information.
Yes, agreed.
Absolutely.
Agreed.
So this is my kind of normal kind of signature question, and it's interesting. I'm going to have to ask two people, but it's fine. Erin, what's next for you?
What's next for me? The beginnings of thinking about an intervention study, and actually now listening to Jason, thinking, yeah, it might make sense to do a case study series first. And I'm working on building my practice back up after going through cancer. My cancer journey got extended a little bit because of a medical mistake that was made. So I'm just finished now, and so I'm hoping to help a lot more people, prevent cancer, get through cancer treatment, and mop up after cancer treatment if they haven't got the information while they were going through it.
Yeah, I mean, your skill set and knowledge in this area now, it just means you're so well placed to help so many women going through a similar journey. And we know it's a frequent diagnosis. So there's so many women that benefit from what you've been through. And that's sometimes the silver lining in horrible of diagnostic events, horrible disease events that occur when we as clinicians work through them, is that it means we're better placed to help others going through similar situations.
Yeah, for sure. And what's next for you, Jason?
I'm still focusing a lot on training clinicians, through the Microbiome Restoration Center, and I'm really passionate about creating what we might call microbiome literate clinicians, of or microbiome analysts, of really lifting the standard there, because I think we can't ignore the microbiome anymore. And most people listening to this podcast will know this already, but the amount of research that's grown in cancer and a bunch of other areas, it's just huge, and that it's really going to be a key component. It should be and will be a key component of how we address Alzheimer's disease, obesity, type 2 diabetes, cancer, all these different things we're seeing all around us in Western nations all have a microbiome driver. And it's really important that clinicians are really substantially upskilled in this area. And that's kind of my passion, is trying to upskill them so they're going to be better placed to move into this new world, because I think, conventional medicine can no longer ignore the microbiome and no longer ignore its role in cancer, for example. That to me is one of the more, areas that I know will drive acceptance of microbiome medicine in conventional medicine, is because the difference in outcomes we get with cancer treatments, that is going to be one of those big leverage agents there. But so that's my current main focus and passion, as well as seeing patients too, because I've been doing this for nearly 25 years now, so you bring a lot of experience to the table in helping people that have had a hard time getting help with others to date, and certainly with that microbiome focus. I mean, it's interesting. You are one of the kind of the leaders in education when it comes to the microbiome, and someone like myself, I'm a clinician. I mean, I've got a real passion for learning more about the gut microbiome, but it seems like it's moving so fast. The amount of information that's coming out, it's almost like trying to nail a piece of jelly to the wall, because you think you've got information, and then there's new information comes out, which is a good thing. It's a good thing. It makes but you're spot on. Like these days, there are nearly 30,000 papers are published a year talking about microbiome. Now, when I started 25 years ago, it was 100 per year. I could read every single paper on the microbiome that was published in my early parts of my journey, and it's impossible now. But I think there are themes that run through, and once you understand those themes about proteobacteria, butyrate producers, bifidobacteria, there's certain things that you see commonalities between all the different disease states. You often see the same bloody dysbiotic state, and it's like the Western diet causes this, exposure to pesticides cause the same sort of dysbiotic state. It's interesting. The more you get into it, the more commonalities you actually see between disease states from a microbiome perspective.
Interesting. So, Erin, where can people find you online? How can people get in contact with you?
At Functional Nutrition MN for Minnesota. Awesome.
Good.
That would be a great place to email me.
You work online with patients too, correct?
I do. I work online with patients, and yeah.
Cool. And I'll make sure your details are in the show notes. And Jason?
Oh, great.
And Jason, where can people find you?
Yeah, the Microbiome Restoration Center is sort of my teaching hub. Then I've got the Hawrelak Gut and Microbiome Clinic, where myself and a few hand-chosen physicians, naturopaths and nutritionists work with patients in a one-on-one capacity. And then the Probiotic Advisor, which is my probiotic evidence-based database as well. There's probably 3 areas to find me.
Awesome. Erin and Jason, thank you so much. I've really enjoyed having you on the show. It's been great having 2 guests at one time. I feel like
it's different, isn't it?
I feel like I've been a juggler for the last hour, but it's been good fun. But yeah, thanks for coming on. Thanks for sharing, your information from your paper. And as I say, I think it's potentially really important information for people to share because, sadly, there is a lot of cancer around these days. There was pre-2021, but it seems like that's gone up a hell of a lot more since 2021, sadly. So, this is really vital information. So again, I'm just going to ask anyone, if you've got to this stage of the episode, please do make sure that you share it with relevant people that are going to really benefit from this great information.
Thank you, Lee. It's really been a pleasure to be here.
Yes, thanks, Lee.
My pleasure. So that's all from Erin, Jason, and me for this week. But don't forget to join me same time, same place next week on the Radical Health Rebel podcast. Thanks for tuning in. Remember to give the show a rating and a review, and I'll see you next time.